Hello. Let's talk about tumors of the upper respiratory tract. All these tumors appear in different locations, so diagnostically this is heavy on the gross images, not as heavy on the histology. Oftentimes you can narrow it down to just one or two different tiny little diagnoses based on the anatomy of these lesions alone. We've got vocal cord nodules and polyps, which are these flat, obviously benign lesions that start popping up directly on the vocal cords. Then we've got respiratory papillomatosis, and this has a HPV Papilloma Virus risk factor involved. You can get juvenile or adult onset forms of that. We've got laryngeal carcinoma, which is an ugly cancer. And again, a laryngeal carcinoma visually is not a vocal cord nodule. There is no way in heck you're going to get those two things confused. And then finally, a nasopharyngeal carcinoma. Well, where is your nasopharynx? It's above your oral cavity. So you're going to have no problem narrowing down that diagnosis. The things that you could get a nasopharyngeal carcinoma confused with are discussed in the previous tumor SDL, the tumors of the head and neck. But within this SDL, everything's pretty well segregated. Vocal cord nodules. They can be bilateral or unilateral, and they can be due to a couple of things. Vocal trauma being one, and speech being another. Of course, what we know about speech is sound waves are mechanical, right? So if you're screaming or really singing for a prolonged period of time, that's a trauma of sorts to the vocal cords. And, well, singing and speaking involve both of your vocal cords, right? So every word that you say, both of your vocal cords are vibrating. And so if you're talking too much or too loudly, both vocal cords are going to be involved, which explains pretty handily why singer's nodules are going to be bilateral on both vocal cords. And then polyps, on the other hand, tend to be unilateral because they don't have anything to do with speaking or talking. They tend to be due to direct, a sort of blunt trauma against the vocal cords. So maybe an aspirated foreign body, right? Knocks against a vocal cord on its way down the trachea. And maybe that's the sort of traumatic event that could trigger a bleeding of the vocal cords. And these polyps have a lot of fibrin and hemosiderin-laden macrophages within them. Nodules and polyps are both pretty benign looking, and when you compare it to a papilloma, well, a papilloma is going to be exophytic and it's going to have fronds like an anemone, and a polyp does not really have that, and neither does a nodule. The big differential between them is unilateral versus bilateral and taking a good patient history. They'll present as a gradual loss of power in speech or inflection, maybe the pitch of the voice changes, maybe there's some pain associated with speaking or singing. And histologically, they are nothing special to look at. They're pretty bland and normal. You've just got this loose connective stroma with an epithelial lining. Polyps generally are big, nodules generally are small, and remember, polyps are generally unilateral, nodules tend to be bilateral. These things are very benign and almost never give rise to cancers. They're just, they're more so a reactive proliferation of connective tissue rather than a proliferation of cells. And we make the diagnosis with endoscopy, which is just a camera on a bendy stick. So I've got some gross images ready to roll here. When we're looking down endoscopically into the larynx, these are our vocal cords, and your vocal cords are called your glottis. That's the anatomical term for it. And I want to help orient you. Every time you're looking at the glottis, it kind of makes the shape of an A, right? because you've got two vocal cords and they're not parallel to one another as much so as they're tethered together on one end and they're free on this other end. And so where they touch at the tip of this A up here, at the apex of the A, I would say, is where that's the thyroid side of things. You've got your thyroid cartilage there, and that's where they're anchored. And that's the anterior aspect of the endoscopic view, versus at the base of the A, down here, where your two vocal cords are separate from one another, that's where you've got your arytenoids and your arytenoid cartilage. So there's two pieces of arytenoid cartilage. There's two arytenoids, one for each vocal cord. So that's how you orient yourself. Those are posterior structures. So every time you're looking down into the endoscope, where the vocal cords meet, that's anterior. Where they have two free edges, that's posterior. So these are nodules, right? And then these are polyps. And obviously a polyp is unilateral. That's your big differential here. And again, just start by orienting yourself. I've made all these anterior on top, posterior on bottom. Just remember that when you're looking down into the larynx, the tip of the A is anterior because, again, those vocal cords make an A shape. Here's a polyp. Remember also we said polyps tend to be large, nodules tend to be small. And polyps are pedunculated, meaning that they've got kind of a stalk attaching them to a surface, but then they've got some mobility, some freedom to move because of that stalk. Back to the SDL. Let's talk about recurrent respiratory papillomatosis. Big association here with human papilloma virus. Strains 6 and 11 specifically can give you this laryngeal papilloma. There are a ton of strains of HPV. It tends to be spread sexually, but it can be spread through direct contact. Can also be passed vertically from mother to child, transplacentally during labor. So these are also papillomas. We just saw polyps, and papillomas are kind of like a polyp taken one step farther. They tend to be pedunculated, and then they tend to have fronds to them. And the correct terminology for saying that is exophytic. Fidic, I believe, meaning pertaining to growth, right? And then exo meaning outwards. So these things grow outwards rather than inwards, which would be an endophytic lesion. And in fact, we did just see an endophytic papilloma with our sinonasal papillomas. Remember, there can be exophytic or endophytic papillomas in that case. And those are going to be on the septum or the lateral walls of your nasal passage. And remember, we said that an exophytic papilloma was like putting a sock on your hand, right? And then an endophytic would be like turning the sock inside out. And then all the fronds that would be outside are going to be facing inwards. That's endophytic. Papillomas in adults are usually solitary. Juvenile form is characterized by multiple lesions that may spread downwards, propagate downwards the airway into the trachea, into the bronchi. And this is a recurrent papillomatosis because these things have a pretty deep hold into the endothelium of the larynx. And obviously, when you go to resect these papillomas, you don't want to take out all of the larynx. You have to leave some tissue preserved for patient functionality, right? And so because these things are often on the vocal cords, you have to have a very narrow margin of resection sometimes to maintain the patient's voice, right? You can't just cut out their vocal cords. So when faced with the decision of should we resect too much or too little, the answer to that is always err on the side of caution. Take out too little tissue, even if you have to leave some of that papilloma embedded in the larynx, because you'd rather leave the patient with totally preserved anatomy rather than cut something out that is of functional use. So that's why these things recur very often. Histologically, recurrent papillomatous lesions are pedunculated masses with finger-like, frond-like projections, exophytic projections of non-keratinized, stratified squamous epithelium supported by a core of highly vascularized connective tissue stroma. So it means that you've got a blood supply and then you've got a lot of squamous dome. You've got a squamous dome around the blood supply. That's it. And then you've got a lot of them owing to the papilloma exophytic grape-like appearance, right? And you see this boy here on the right, and yeah, that clearly looks like a cluster of grapes, and that's going to be your buzzword or sort of pseudonym shortcut for describing the gross appearance of these papillomas. And again, remember we said when we are looking at the larynx, right here at the apex of the vocal cord A, right? This is your anterior larynx, your anterior glottis. And then back here, well, you've got 1, 2 attachments, right? And those are going to be your arytenoid cartilages. And so this is the posterior side of your larynx. And so that's how you start, is by orienting yourself. And then we come over here and we can tell, well, there's a vocal cord going like that, and there's a vocal cord going like that. So then in this picture on the right, the view is flipped. And at the top of the right image, you see your anterior glottis. At the bottom, you see your posterior glottis. So then that's also going to help you, you know, because maybe you get a question where it's like, maybe it's like, what are you seeing? And it's like papilloma on the left vocal cord, papilloma on the right vocal cord. Sometimes you'll just get tested based on pure anatomy, you know, and you got to know it. So here's what it looks like microscopically. You can tell that this is the sort of histology you would see if you took the fingers of your hands and cut them off and then looked axially at them like that, right? Like top down at the nubs of your fingers. And so that's the orientation here. You can tell we're looking axially at a sea anemone that we've chopped off the fronds of. And what we see here is we've got a core in the middle that I'm outlining in red, right? We've got this core, and we can see that there are lots of blood vessels inside this core. But then I'll put this in blue here. We've got this big, thick, stratified squamous epithelium around each core. And that stratified squamous is staining darker than the connective tissue core just by virtue of the higher cellularity, because squamous cells are all pressed together. So before we get into the etiology and risk factors of this, let's take a farther look at this papillomatosis grossly. It's exophytic, and anytime you see exophytic, you ought to be thinking viral infection or some sort of infection, because cells don't normally pop up with papillomas unless they are infected with an outside agent. And when they're on the mucous membranes, specifically on the genitalia, papillomas are basically warts, and they're called condylomas. They can be called condylomas. And so condyloma lata is a genital presentation of syphilis and of HPV. So that would be seeing something that looks very similar to what you're seeing here on the larynx, except on the genitals. And so that's going to lead into the risk factors, which do include sexually transmitted diseases. And that's how juveniles get this RRP typically, is because the mother has genital HPV, and then the virus sloughs off and infiltrates the baby through vaginal delivery. So here again, we're looking at, you can tell that that's the angle of the vocal cords. So we're looking at the anterior glottis here and the posterior at the top of this image. And then here's a vocal cord, and then here's anterior. So we know that this here is going to be our left vocal cord, and then this is going to be a exophytic papilloma supraglottic, but with glottic involvement on our right vocal cord. And again, these things tend to reoccur because, well, like I was saying, if you want to cut this dude off here on the left, if you want to cut this thing off, or this thing here, well, it's all over the vocal cord. So it's like, when do you stop cutting, you know? So you got to stop at some point. And here's what it looks like histologically: pedunculated with finger-like projections. But the big thing here is non-keratinized stratified squamous epithelium. And non-keratinized is pretty big. Remember that epithelium becomes keratinized as it dies and dehydrates. And keratinization is like its living will, basically. It's the last thing it chooses to do before it kicks it. And a keratinized squamous cell has only a few days on the surface before it just gets pushed off by more squamous cells growing up from the basal layer of the epithelium, of the mucosa, or of the, ectodermal layer. And here at the bottom, we see highly vascularized connective tissue. Well, this isn't particularly connective tissue, but this slide here does have 3 capillaries in the same frame, you know, so that's pretty vascularized. And one more time, the noteworthy finding histologically is the fat squamous cell layer. Here's what it looks like in a kid when the papillomatosis that starts at the vocal folds starts moving downwards and encroaching down the airway into the trachea, into the bronchi. So you really feel, you know, because that's tough. So let's get back to the SDL. Again, how do you get this disease? Human papilloma virus all the time. Papillomas are not something that just spring up. There has to be an infection. 95% of laryngeal papillomas are positive for human papilloma virus DNA. It is a DNA, double-stranded DNA virus. It's not enveloped. It has an icosahedral capsid, but everything but pox virus basically has an icosahedral capsid in the DNA family. Again, double-stranded DNA. 6 and 11 are low-risk types. 16 and 18 are high-risk types. And that's all I'm going to say about this, because I think that's all you need to know for this SDL. But for boards, I mean, there's tens of HPV subtypes, and there are vaccinations against certain ones, and then certain types cause certain infections. And so that's something that you ought to be familiar with going into your second pass of all this material. Vertical transmission can occur. Firstborn children have a higher incidence of this RRP pathology, and the doctor word for firstborn when you're referring to the mother is primigravid or primigravida, meaning this is your first labor. So know what that word means. And then risk factors for adult onset recurrent respiratory papillomatosis is going to be sex, because that's how HPV spreads. Symptoms: hoarseness, like we said. Maybe you get pain. Maybe you get a little bit of respiratory symptoms. Acute respiratory distress, yes, possibly, but by that time, hopefully you already know that the patient's got papillomas going all the way down their airways. In other words, hopefully they've already seen the doctor before the point where their symptoms progress that bad, so you at least have a diagnosis there. Juvenile onset tends to be more aggressive because kids don't really have a fully formed immune system yet. And again, these tend to be multiple tumors and bigger tumors as well. And if you see it spread down the trachea, it's probably a kid, not an adult. Now let's discuss laryngeal carcinoma. This is a big bad cancer. This is one of the most common cancers above the shoulders, if not the most common, I think. This cancer is the don't smoke or you'll end up like me. It's that cancer, okay? So hugely, enormously, astronomically associated with smoking, 6 times more often amongst smokers than non-smokers. And alcohol has that synergism with it because, you know, whenever you're drinking a beer, you really want a menthol. And then sometimes you're smoking a menthol and you're like, man, a beer would be nice right now. And so those things go together, and alcohol by itself does not seem to increase your risk of laryngeal carcinoma, but it sure does. Alcoholics or people who drink tend to also smoke at higher rates than non-drinkers. And that's where we start, is by discussing the risk factors. Smoking has a couple of buzzwords with it. Polycyclic aromatic hydrocarbons, PAH, that's a carcinogen. And then nitrosamines, that's a different type of carcinogen. And nitrosamines are also found in smoked meats and, stuff like, I don't know, Hormel pepperoni, or like those Slim Jims or something like that. Just that protein that's just no good for you, because it's like there's just like a dime worth of salt in one of those sticks, right? And then they're smoked too, which is just really, it generates free radicals within all those proteins. So even though it's got a lot of proteins, well, they're not the best proteins for your body. And in order to cope with the huge load of free radicals, you have to have certain enzymes that can quench the radicals generated by these carcinogens. So the carcinogens too have to be metabolized to excretable forms or to non-toxic forms. And in the process of modifying these carcinogenic shapes, maybe you generate a radical that way. And so if you don't have enough enzymes to metabolize all the polycyclic hydrocarbons that are associated with one entire cigarette, well, then all of the PAHs that you don't metabolize in time, the longer it takes for you to metabolize those things, the greater the probability is of one of these carcinogens just picking up an electron from somewhere and becoming a radical and then going along to damage other intracellular organelles and components and proteins and sugars and fats. So treatment, number one treatment is almost always stop smoking. Unless it's a clin med test and there's a patient with a clot in the leg and then you put a compression wrap on them. Alcohol, the risk is increased by association with smoking, but no particular alcoholic drink seems to be implicated, and we don't know what's going on with non-smokers, but we again do know that if you drink, you're more likely to smoke. If you smoke, you're more likely to drink. And because smoking is the number one here, if you drink, you're more likely to smoke. Well, that's why alcohol is there. It's there by association. Other risk factors, this one's fascinating. Gastroesophageal reflux, because you got some acid popping up from your esophagus and it can spill over into your larynx, and the acid is going to really irritate the respiratory epithelium of your larynx, and maybe it can induce a dysplasia and get that to turn into a squamous epithelium, right? Or maybe it can turn into a hyperplasia. Bottom line is that acid coming up from the stomach is a stress on your airways, and you do not want that acid in your airways at all. Finally, patients with HPV positive laryngeal carcinomas. We just said HPV can give you a recurrent respiratory papilloma, right? But it can also give you a laryngeal carcinoma. And there's no rule that says HPV will always cause this type of cancer. It's going to damage cells, and that non-specific damage can lead to a whole lot of different cancers. So strains 16 and 18, the high-risk HPV strains, are associated with laryngeal carcinomas. What do they look like clinically? Well, we classify them chiefly by their gross anatomical location, and we classify them relative to the glottis. And glottic means at the level of the vocal cords, okay? And so then where is supraglottic? Well, it's going to be up here above the vocal cords, right? And then where's subglottic? Where subglottic is going to be down the trachea beneath the vocal cords, okay? So an important term to know at least recognize that this is a thing, this exists. You know, you don't got to be able to draw it in your sleep. But if you hear rheumatosis, rheumatosis is the space in between the true and the false vocal cords, okay? And your false vocal cords are always on top, and then your true vocal cords are underneath them. And the little vestibule or the pouch or the space or the pseudo chamber, the atrium, whatever you want to call it, in between the false and the true vocal cords underneath, that little pouch is your rheumatosis. So look that up if you're not too keen on the spatiality of the anatomy there. Glottic cancer, again, if you have something growing on your vocal cords, do you think that the pitch or the tone or volume of your voice will be affected? Absolutely. Supraglottic cancer is typically not going to play with the voice because the vocal cords aren't impacted, but it can certainly cause a lot of pain. It can cause some difficulty breathing. You may notice a mass if you're the patient, and it can cause dysphagia because remember that the trachea is right next to the esophagus, and so if you have a compression of the larynx, the upper airways, then it's going to encroach into the space occupied by the esophagus. Subglottic cancer is much more rare, and it's also very difficult to image and visualize. Basically, patient's going to be in a pretty bad state by the time this gets diagnosed. When diagnosed, most tumors are classified T3 and T4, and so that's exactly what I said. Patients are going to be in a pretty bad state because T3 and T4 are large, and that's compared to T1, which is like really tiny. And that's our TNM method of tumor grading. I want to say it's grading, not staging. Let me double check that, because you got to know grading versus staging. Actually, I think that TNM is staging. Yeah. So TNM is tumor staging, and then grading is looking at the histology of it. So T stands for tumor, which is just going to be how large is it, you know, in millimeters or centimeters or whatever. And the N is going to be nodes. So how many lymph nodes has it spread to? So you can have an N1, N2, N3, N4, depending on how far that gets out. And then M is going to be metastasis. And that's basically a yes or no. And you can have different grades of metastasis, or you can have a B in that column for benign, right? And that's the most important prognostic grade, because as long as a tumor stays contained within its locality, well, then it's not really threatening other systems of the body, and you can really manage it with resection with a good knife. So then we start to talk about the histopathology of these tumors. As they get worse, you start to see hyperplasia, you start to see hyperchromatic nuclei, you will start to see more numerous mitoses and larger nuclei. So all these changes here are going to be basically a progression as things go from better to worse prognosis. The more atypia you have, the worse that tumor is. The more mitoses, the larger the nuclei are, the more stain it picks up. The more nucleoli you see, the worse that tumor is. And so that's what we're thinking here, because you might get shown a benign laryngeal carcinoma, or you might get shown a laryngeal carcinoma that's just so far gone, you know. So being able to get an understanding of how far developed is this tumor, how dedifferentiated is it, just by looking at the histo, that's an important skill to have. Then this is where the organization of the SDL starts to kind of fall off. I don't think these few pages are particularly nice, because it talks about exophytic and endophytic lesions. Then it just starts talking about squamous cell carcinomas out of nowhere, and it kind of misleads. It can potentially mislead one to believe that it's talking about an exophytic lesion as though it's something totally different than a squamous cell carcinoma. But no, like both the exophytic and the endophytic lesions tend to be squamous cell carcinomas. And then there's this other variant called the Virtuous Carcinoma, which is a very small percentage of the time. Bottom line is that most of your laryngeal cancers are going to be exophytic, endophytic lesions, squamous cell carcinomas. So again, exophytic means it's popping out. Endophytic means it's popping in. And here it is in the text. 95% of all laryngeal carcinomas are squamous cell carcinomas. So understanding a squamous cell carcinoma, carcinomas meaning basically it's of in ectodermal lineage, okay? And squamous cells, if it's well differentiated, you'll see keratinization, keratin pearls within the tissue. Because again, what does well differentiated mean? Well, it means the cells look like how you would think they would look. But then what does de-differentiated mean? It means the cells kind of go back in time and they start all looking like stem cells. So well differentiated means they're more terminal, de-differentiated means they're more baby. And you don't want your cancer to look like a bunch of baby cells because that means that it's got access to the entirety of the genome, right? So it can make whatever proteins it wants. And as long as it's an endothelial cell, right? Well, there's a lot of proteins that it can't make. And so it can't grow nearly as quickly because its toolbox is limited to things that an endothelial cell can do, right? And so when you're a de-differentiated cell, well, you've got the endothelial toolbox, the mesothelial toolbox, and you've got the neuronal toolbox, right? And then you've got the muscle toolbox. You can make any protein you want if you're a stem cell. So that's why differentiation is so lethal in the hands of cancer, because a cancerous cell that is only seeking to grow and divide without consequence is going to use all of the tools that it has at its disposal. So differentiation basically means you're limiting the tools at its disposal. So let's start to really break down the text here because I don't want to gloss over anything. You go from pre-invasive to invasive, and invasive is going to be your malignant cancer, because remember that metastasis can only develop when the basement membrane of a tissue is penetrated, and the basement membrane has lots of collagen 4 in it, and so to cut through, chew through that basement membrane, a tumor must express a tumor must alter the environment enough to get matrix metalloproteinases really upregulated, and other cells will help make the matrix metalloproteinases. So the cancer cell doesn't have to make all these scissors and saws by itself. It can just turn its environment really acidotic, right? Or maybe it'll deprive all the other neighboring cells of oxygen, and that'll be the trick to get some MMPs, matrix metalloproteinases, out into the cytoplasm. And if there's enough, well then the basement membrane just gets ablated chemically by all these molecular scissors again. So pre-invasive means it's still there in the tissue, and invasive means it can move elsewhere, and it's moving into the tissue first and foremost. So invasive carcinomas are going to have more fronds to them. They're not just going to be like bland balls. They're going to have arms and legs to them, you know, histologically speaking. And this is again showing you supraglottic, subglottic. This one's subglottic because right here, that's a terrible arrow. Right here is the level of the vocal cords. Right there, right? So that dark line in the middle of the picture, that's your vocal cords, and you've got a subglottic cancer right down there, and you can just tell that it's not smooth airway, it's not smooth mucosa. And then here, well, what are we looking at here? Well, that's where the epiglottis ought to be, okay? And the epiglottis, remember, is that flap that's going to protect your trachea whenever you're swallowing, and then it's going to protect your esophagus whenever you're breathing. It's going to flap up to allow you to breathe, and so that's what your epiglottis does. And obviously, if you get a carcinoma on the epiglottis, then that ain't no joke. Histologically here, the top of page 9 is discussing what do you see in a squamous cell carcinoma. You see epithelial cells with various degrees of dedifferentiation. Tumor cells are large and polyhedral with ample eosinophilic cytoplasm and large irregular nuclei. You might see keratinization with squamous pearls. You can see intercellular bridges, and the squamous pearls is a big deal because if you see that, you know you're looking at a tumor that's somewhat differentiated. It's still differentiated, so that's a good thing prognostically. And then down here, the grade of the tumor. Okay, remember we said staging is the spread and like the spatiality of it all. And then grading is, okay, let's look through a microscope and see how have these cells changed. And this tells you what to expect in a benign, non-invasive, well-differentiated tumor, lots of keratin pearls, everything looks like epithelium. And then the farther you go up towards a grade 3, the less and less epithelial it looks, the more it just looks like a bunch of randomness thrown together like this here, you know, like you can't really tell what cell types those are. There's no keratinization, there's no layers, it's just a big blob of cells. And so that's a poorly differentiated carcinoma. And then we get into the verrucous carcinoma, which occurs very often in the oral cavity in addition to the larynx. And then you can get a verrucous carcinoma on the genital perianal area. And if you see it in the oral cavity, it's most often associated with chewing tobacco, smoking. If you see it down between the legs, then it's most commonly associated with HPV Papilloma Virus. And these are exophytic, warty-like tumors. Exophytic, again, meaning they pop out. And it's going to produce keratin. It's going to stain positive for keratin. So remember that we differentiate tumors from one another by what sort of immunostains they pick up, and cells from different lineages will express different proteins that allow different immunostains to bind to the surface of those cells. So that's the basis of our differential pathologically. Microscopically, here's the histology. You've got a densely keratinized layer covering large papillary fronds and a sharply circumscribed deep margin. And this is a good time to remind you that way back up with our recurrent respiratory papillomatosis, right? This is a non-keratinized squamous epithelium, okay? And that is reasonably important because that's going to help you cellularly differentiate this dude from a laryngeal carcinoma, a papilloma from a carcinoma. And this is benign and it's non-keratinized. So back to the verrucous carcinoma. You see a lot of keratin, and then you see some thick membranes, and finally it's well circumscribed and demarcated from the adjacent mucosa. So before we go farther, let's take a look at some of these laryngeal carcinomas, cancers. Here's what they look like grossly. And again, you can tell that this is some pale tissue, right? This is some very sickly looking tissue. It needs some help. And this is very in contrast to something like a nodule or a polyp, which was still relatively red in appearance. This tissue is pale because the tumor is having adverse effects on the normal cells of this locality, meaning that it's depriving them of oxygen, or maybe it's depriving them of glucose because tumors are glucose vacuums. And maybe it's also releasing a lot of lactate due to the Warburg effect, which is the tendency of tumors to participate in anaerobic glycolysis, which produces lactic acid, which comes with a lot of protons, and that's going to flood the surrounding neighboring cells with a low pH and damage them over time. So this is a supraglottic laryngeal carcinoma. Let's orient ourselves right. You see a vocal fold there. You see a vocal fold there. You know that the point or tip where the two vocal cords meet is going to be anterior. So, you know, posterior is back here. So, you know that we're looking down, and this is going to be your left vocal fold then, right? So this is a supraglottic carcinoma on the left side. And you can tell that it's supraglottic because this cancer does not go down onto the vocal folds. It just stays above it. So above supraglottic. And then same thing here. It's not easy to tell that this is supraglottic and not glottic, but generally the body of this tumor is above the vocal folds. And so this is a supraglottic tumor that could potentially gain glottic involvement and orient ourselves right. So anterior, and then we see two bases down here, posterior. Again, you got your thyroid cartilage anteriorly, and you got your two arytenoid cartilages posteriorly. Now we're looking at glottic laryngeal carcinomas. This one down in the lower left is the most mild. So this one's flipped, right? Now we're looking at the anterior is at the bottom of the screen, and then posterior would be up here. And so that's the axis of orientation of this gross pathology, which means that this is a left vocal cord glottic carcinoma, left glottic carcinoma. And this one's in the baby stages here. And this is fortunate to have caught, they're fortunate to have caught this one so early because it can obviously progress to where it's large, 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 as in the case here. That's going to be a right glottic carcinoma. And again, they're glottic because they are literally on the true vocal cords, right? And so also, side note for some anatomy, that's the margin of the true vocal cord. Now I'm going to take blue and I'm going to draw where the margin of the false vocal cord is. There's where the line of the false vocal cord is. So that's another line of the false vocal cord. So right, we've got here in green, the free margin of the true vocal cords. So if we're looking top down into the larynx, what we see is that the true vocal cords are deeper than the false vocal cords. They are underneath them. And so the false are right here. And they are all of this tissue up in here, right? And it's going to have the same structure as like a ring and then another ring. That's what we're looking at. And so there's going to be a pouch or a chamber in between these rings. And that's where the rima glottis is, or the rima glottis, right? And so you can tell that there's a shadow here. And you can tell that if you went into this shadow, if you approached it from the side, right, you could kind of stick your finger up into that shadow. And that's because there's a pouch in between your false vocal cords on top and your true vocal cords on the bottom. And so if you were to stick your thumb down into that pouch, that's the rima glottis. And bottom right here, this is wicked cool, yo. This is a laryngeal carcinoma in the process of being surgically ablated. So it's not normally going to be this pale and vascularized, but this tissue is currently under a high degree of stress because somebody's taking a blowtorch to it, essentially. And again, you got to be very careful with these things. You want to resect the whole tumor, you know, but you obviously don't want to rip out the patient's vocal cord. And so this is a real microsurgery. Again, these are malignant squamous cell carcinomas. They're squamous cell carcinomas 95+% of the time, and they also tend to be malignant too because, well, they always go from benign to malignant, but you rarely see symptoms when they're benign. You're typically not going to see symptoms until these things become malignant, which is why I said that this tumor in the bottom left, you know, like really good for them to have caught this carcinoma when it's in such an early stage because it's rare that you do. Let's look at the histology. This is a well-differentiated squamous cell carcinoma, and you can tell that because you can tell it's well-differentiated because there is a lot of keratinization within this cancer. Let's go green here. So this whole nest is surrounding some epithelial cells. Particularly, there's a high degree of cellularity out here at the margins of this zone. And then as you move towards the middle, obviously, you see there's a dense acellularity in the middle, which is pretty bad because that reflects tissue necrosis. But the cells on the outside, the outer margin of this shape, they are still quite obviously epithelial cells, you know. And so we said the less differentiated a cancer is, the more it just looks like stem cells, right? And so you look at these and you're like, well, those are epithelial cells. So that's a low grade carcinoma here. Remember, grading is what does it look like under the microscope, and staging is how far has it spread throughout the body. We're taking another look here at a low-grade carcinoma, squamous cell carcinoma. This is the left vocal cord, and it's got nests of malignant squamous cells in the submucosa. So we know we're looking at the true vocal cord because we look at the outer epithelium, the surface epithelium here, and it's a stratified squamous epithelium, and our false vocal cords are going to have a respiratory epithelium attached to them. And so we go on down, and that's going to be our epithelial layer. And then we've got a lamina propria, right? And then we've got a basement membrane along here. And then this is our submucosa area from here to the bottom. And so we're looking at a nest of cells that should not be in the submucosa. And so that's how we know it's cancer, is because it's like, well, if the basement membrane's here, everything underneath the basement membrane should basically be loose connective tissue and glands. And so because we see this big island or pocket of squamous cells, we're like, you're in the wrong place. And then we zoom in and we see that yes, these cells look very epithelioid, right? They're starting to differentiate a little bit, but you can look at a big cell like this, and like that's a keratin pearl, right? That's got a lot of keratinization to it. And you can look at another cell here, you know, and like they've really got the polyhedral shape characteristic of some epithelioid tumors. This one's starting to de-differentiate a little bit. It's got a big swollen nucleus, and you can see the chromatin and the nucleolus inside of it. It's it's preparing to be mitotically active. It's going through a growth stage right now. You see a lot of keratinization here. Again, how many nuclei do you see in this region? Well, there's this one here really, and then there's like one right there. But then this is a large anuclear zone, so that tells you there's a lot of keratinization here, so it's a well-differentiated tumor. Here is another well-differentiated squamous cell carcinoma. You've got keratinization at the surface, right? You've got keratinization at the surface and even way deep within the submucosa. So again, keratinization, high-grade tumor. And remember, going back to our recurrent respiratory papillomatosis, you do not see keratinization in this sort of tumor here, this sort of growth. You see non-keratinized stratified squamous. So then let's flip back over to our laryngeal carcinoma and notice its keratinization. And we're really going to spell it out now. The keratinization in this slide is pinker than the surrounding tissue. It's got a little bit more red tinge to it, right? So this layer here is very keratinized. This whole pearl, this sphere here is very keratinized. But then we zoom in, and this layer of the epithelium is not as keratinized. And then right here in the middle, we see a really good cutoff, right? This part of epithelium, not so keratinized. This part of epithelium, you notice how it's a little bit redder. It's a little bit more salmon instead of that baby pastel pink, okay? That's the keratinization. And you can tell, even if this were black and white, you could tell keratinization because these cells here on top of the epithelium, these cells here have a lot of space in between their nuclei, and you can tell they're very flat and thin. And remember, we said that squamous cells thin out as they acquire keratin, and that's kind of the last thing they do is they keratinize themselves before they're pushed off the surface. And then these squamous cells down here are far more polyhedral in shape. We're looking at these squamous cells down here, and they are non-keratinized squamous cells because they are plump and they are not thin. Because keratin, the presence of keratin, dries up a cell and makes it flatter and thinner. So that's keratinization of a squamous strip of tissue. Here is a poorly differentiated squamous cell carcinoma. I wanted to include at least one of these so that you know what the invasive, more prone to malignant, grade 3 or grade 4 variant of squamous cell carcinoma looks like. And here we notice we're not seeing a lot of keratin at all. We're not even seeing a lot of keratin up close to the tissue surface here. We can tell that this is a pretty non-keratinized epithelium actually, because notice how large and spread out these individual cells are. Let's go a little bit thinner here with the pen, and we'll see. Yeah, look at this cell. That's a fried egg. That's a pancake type cell. That's a polyhedral type epithelial cell. This is a polyhedral type epithelial cell. So what did we just see in the last image? A bunch of flat cells, right? And we called them pancakes because they're going like that. They got like onion-like layers, and that's how we knew it was keratinization, was because these cells had all these flat layers to them, right? Right there, all these layers. And you don't see that in this dedifferentiated tumor. There's no keratinization. And because keratin is particular to endothelial cells, that means that these cells are shifting from their endothelial adult form, reverting back into their baby stem cell form. So they're still using some of the endothelial tools in their toolbox, but they're not dependent on them. So they're not going to express this keratin if they don't need to. And then we look into the submucosa here, and what do we see? Just a bunch of, yeah. I mean, there's just extremely evident hemorrhage and necrosis down in this region. And then elsewhere, you just see so much cellularity and atypia because you can't tell what these cells are from a mile away, right? You really have no clue what sort of tissue you're looking at. If you were to zoom in all the way here, you would just be like, oh, I'm looking at some mesenchymal sort of general connective tissue, which is not a good prognosis for a localized cancer, right? And again, we are not seeing keratin pearls. They would be big, puffed up acellular type spheres if they were here, but they're not here. We're not seeing them. So this is a higher grade squamous cell carcinoma. Now we're looking at a verrucous carcinoma. Here's one on the genitals. Here's a couple on the inside of the mouth. Remember the associations here. Human papilloma virus, anytime it is down between the legs, and then smoking and especially chewing tobacco anytime it's in the mouth. So these are also squamous cell carcinomas, but they sort of take a different route of protein expression. They are pretty keratinized on the surface, as we can tell by, remember we said keratinization is pink, 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 red, pink, way more salmon, kind of hot pink in this stain. There's a lot of stain being used here. So a verrucous carcinoma is keratinized on the surface, and that'll help you differentiate it from a papilloma, a normal papilloma, right? So the verrucous carcinoma does have papillary fronds like a papilloma, so it'll be exophytic grossly like a papilloma, and it's got a sharply circumscribed deep margin, which I've outlined, I've dotted here as number 2, you know, so there's the circumscribed deep margin. You can tell that there is a membrane there going around a certain depth of a layer of this papilloma. And then you've got these bulbous downgrowths, and I'll sort of outline a couple of them, you know, like that's a bulbous downgrowth. That's a bulbous downgrowth. This is what they're talking about when they say bulbous downgrowths. So there's one, there's another one. So that's that. And then one more time, that very keratinized layer on top. Here is a verrucous carcinoma. And look at the keratinization on the very top of this tissue. Look how flat and super, super, super pink, magenta almost those cells are. And they're squamous cells. You can tell they're squamous cells. And you don't see keratin pearls down here, right? So you're like, okay, that's probably not a run-of-the-mill low-grade squamous laryngeal carcinoma. And depending on where the gross biopsy too is, again, if this is on the corner of the mouth, you're like, well, that's not a laryngeal carcinoma, you know. So it's got these papillary fronds. Again, those are the downgrowths. That's a downgrowth. That's a section of downgrowth tissue. It's kind of lobulated in the fact that it is growing down in pieces like octopus tentacles. These are really cool squamous cells. Look at those, Johns. Yo, it's just fascinating. So that's all we got for verrucous carcinoma. And I think it was mentioned in the text that the cells of this carcinoma, let's see. Running through this one more time. Yeah, well-differentiated squamous epithelial cells that show a broad pushing rather than an infiltrating border, right? And so it doesn't have an infiltrating border because there is clearly like a margin on the deep aspect of this cancer. And then even here, sharply circumscribed deep margin. It's got a border around it. It's circumscribed. So that's your verrucous carcinoma. And that's this here in the middle, like these cells are spreading out and pushing each other out. They're exerting force on one another. Back to the STL. Sorry to take up all your sweet time there, Laryngeal carcinoma, if it spreads, it tends to spread into cervical lymph nodes, and that's a fat differential right there, swollen cervical lymph nodes. Metastasis, again, is a terrible prognosis, and that's that M part of the T&M staging system. Staging, meaning the spread physically of the tumor. Grading, meaning the microscopic appearance of it. How do we diagnose these? Endoscope. We look down to the larynx, and then we pinch off a little bit of the tissue and put it under a microscope. We might initially discover the tumor on a CT or MRIs, most of the time non-incidentally or accidentally, rather. But then if you want to determine if you want to stage the tumor and figure out how far is it spread, you do need the MRI. This is historically a very debilitating cancer. Again, it's the patient with the hole in the front of their throat permanently. We're able to care for these a lot better now with chemotherapeutics, and we're able to definitely prolong the time that it takes for a patient to progress to the point where they do need that tracheal surgery. And that is our therapeutic goal. That's our number 2 goal behind preserving the life and health of the patient, is preserving the functionality of their voice. Prognosis of glottic laryngeal cancer has a better prognosis that is much better than that of supra and subglottic cancer. And the reason for that is because, well, if it's on your vocal folds, there's only so deep it can grow into your vocal folds. They're like a few millimeters thick. But if it's above or below the vocal folds on the wall of the larynx, well then, man, that sucker could just grow straight through and straight in, and your larynx is invested with so much blood vessels to where the risk of metastasis and then spread to a lymph node, because the walls of the larynx or the mucosa, that layer is especially invested with lymphatic channels. And so if it's growing into the walls of the larynx, then it'll spread quickly at a higher rate. And then if it's growing into the vocal cords, well, there's only one way it can go, and it's like, it doesn't matter if it grows exophytically off the vocal cords, it can grow outwards all at once into the lumen. You're just going to cut it off, but if it grows inwards into the tissue, that's bad. Page 11, nasopharyngeal carcinoma, huge association with Epstein-Barr virus, which is a herpes virus. It's human herpes virus 4. It likes to get inside B cells. It can cause a B cell lymphoma. You're going to see some really weird T cells too, and they're called Downey cells. And they're going to be T cells that have nuclei that look like you just took your thumb and smudged them. That's what these Downey cells look like in Epstein-Barr infection. And finally, Epstein-Barr is really associated with mononucleosis. That's typically the initial presentation of the disease. And then it being a virus, it will go latent within B cells, and it'll hide out within the B cells of the body for a long time and then reactivate. And when it reactivates, that's when you see the occurrence of all these EBV-associated cancers, right? So EBV, most of the time, the initial presentation is mono. There's a latent period. It reactivates, and it gives you cancer. That's what we're thinking of here. Nasopharyngeal carcinoma, also called lymphoepithelioma. It's got a characteristic geographic distribution, meaning it's basically endemic to certain parts of the world, namely China and Equatorial Africa. It's got a huge correlation with Epstein-Barr virus. And then you often see these things pop up in non-smokers non-drinkers. And so that's what makes you say, oh, hey, have you ever had mono, you know, and then describe it to them. And they'll be like, oh yeah, I had that. Cause you know, mono, you don't forget having mono, you know, you have mono for months. So it's like endemic areas, again, Southern China, the incidence is huge. So the population distribution of this, you know, remember how rheumatic fever had endemic areas, same concept here. What does it look like? Well, it's in the nasopharynx. Check. Raised nodule with or without surface ulceration, or it can be an infiltrative fungating mass. So it can be papillomatous in nature. The most common site of origin is the lateral wall of the nasopharynx, especially the fossa of Rosenmuller, a pharyngeal recess located behind the opening of the eustachian tube, followed by the superior posterior nasopharyngeal wall. So know this, because this has got to be given to you in a test question, right? They have to tell you where this tumor anatomically is in a patient. And that goes for all tumors, you know. So tumors that have distinctive presenting locations, understand those, know those. It's something that doesn't take a lot of effort to learn. It's just like, oh, okay, there's my diagnosis, you know. Versus the histology. Now, this is going to be the next step of something that you learn. A lot of squamous cells here. You can see undifferentiated nasopharyngeal carcinomas. We'll look at both of those. Squamous cells obviously are going to look like squamous cells. And you're going to typically see a lot of keratinization, but the cells will definitely have the general shape of squamous cells. Undifferentiated carcinomas, here's the words that's going to go with the pictures we're about to look at. The tumors are composed of sheets of large undifferentiated cells with indistinct borders and a population of non-neoplastic small lymphocytes. And so that's the T cell response to this tissue growth, right? And because it's associated with a virus, there's even more lymphocytes than there would normally be with a tumor. So this is a squamous cell variant of nasopharyngeal carcinoma. And we're seeing some tiny little islands of keratinization. We're seeing, here's a broad little strip of keratinization. Right here in the middle are some keratinized looking epithelial cells, meaning they're very flat. Here's a decent little bundle of a bunch of pancake-like epithelial cells squished together. And then what we're also going to see is a bunch of large nuclei, small cytoplasm lymphocytes. So you've got a bit of a lymphocyte population up here, right? And then when we look at an undifferentiated carcinoma, it's a lot different. Grossly, there's a ton of lymphocytes up in here, especially this little outline here. I mean, there's nothing but lymphocytes in that area that I just circled. That's what it looks like to me. And then here is a patch of lymphocytes. There's, again, nothing but lymphocytes in there. Here we see a respiratory epithelium letting us know that we are in the pharynx or larynx. You might say, oh, well, here's some epithelial cells here, but again, you got to make sure that's not just the normal tissue architecture rather than the cancerous cell itself. And in this case, the cancerous cells are going to be basically everything admixed with lymphocytes up in here. And they don't look like any particular cell type at all because it's undifferentiated. Here's another example of it. Again, you're looking at this. What type of tissue is this? You have no clue. All you know is that you see a patch of lymphocytes down here, right? Like, and then other than that, you have no idea. And so because you can't pick out like one cell type, okay, undifferentiated. Here's another example. We're zoomed out here. This is medium magnification. It's like, what sort of tissue are you looking at? You have no idea. Undifferentiated carcinoma. Back to the SDL. So most are squamous cells, some are undifferentiated. Really no change in where you see the tumors, just the histology of them. So the histology for nasopharyngeal carcinomas don't matter that much. Lots of kind of biochemical jargon for this particular cancer, 3 whole pages worth. So let's get started unpacking it. It's associated with EBV, which again is going to be a double-stranded DNA virus of the herpes virus family. And Epstein-Barr virus desires to enter B cells. and it does so through the CD21 receptor. And it's very important to know that the pharyngeal epithelium also expresses CD21. So CD21 is how Epstein-Barr gets into its host cells. And typically its host cell is the B cell. But the pharyngeal epithelium can also play host to Epstein-Barr virus. So Epstein-Barr typically presents initially with mono, and then it goes latent, and then it hides out in B lymphocytes and in the pharynx, and then it represents as nasopharyngeal carcinoma or Hodgkin disease or Burkitt lymphoma. Burkitt lymphoma, please remember, is a chromosomal 8 to 14 translocation of the CMYC oncogene, which is a growth factor receptor, I believe, and more activity of that gene, more transcription of that gene is going to allow cells to get through their G1 phase into the S phase even quicker. So that's your Burkitt lymphoma. And a lymphoma is a oma, it's a neoplasm of a lymphoid cell, a white blood cell, right? Reactivation is what it's called whenever the Epstein-Barr virus starts just messing up the host cells, going all Terminator on the inside of them. And it'll start popping out more and more and more and more and more copies of itself. And so that's the lytic phase, the reactivating phase. So that's what's going on right before the development of this cancer. And so the virus is reactivating, causing a lot of generalized local inflammation inside the B cells, or the larynx particularly where it's at, right? Or the pharynx, my bad. And so this causes inflammation in the pharynx. Cells react to that inflammation by dividing and swelling, and then they divide too much, and then there's a mutation thrown in there as well because of the Epstein-Barr virus and its interactions with cellular DNA, and well, that's how you develop this carcinoma. Three patterns of latent gene expression. I don't think this is huge to know, but if you get asked about it, it's not difficult to remember. It's pretty easy, actually. Latency 1, you express one important protein. Latency 2, you express two important proteins. And then latency 3, you express all possible viral proteins. So just walk down the line. One protein, EBNA1. Two proteins, LMP1 and 2. 3, all the proteins. And then also the question that could come from this is, oh, well, the patient's, you take a biopsy of the cancer and cells are infected with EBV staining positive for EBNA, but negative for LMP. So what's the other cancer that you're worried about this patient catching? And the answer to that's going to be Burkitt lymphoma, right? Because Burkitt lymphoma is characteristic of latency 1 infections. And then another example would be like, oh, well, you biopsy this patient's swollen lymph node and it lights up for EBNA1 and LMP1, right? But negative for EBNA3. And so that's where you say, oh, okay, I suspect Hodgkin disease, or the patient might get nasopharyngeal carcinoma. So that's, and then latency 3, post-transplant lymphoproliferative disorders. We'll get to transplants and undifferent SDL. So the biochem of all this, nuclear factor kappa beta is a growth associated signaling pathway. The more NFKB you have, the more cells are going to grow, the stronger they're going to be. It's really all that's saying. I don't think you can test us on that because, again, I mean, there are people whose entire careers are dedicated to signaling pathways, and that's not us. EBV LMP1 inactivates P16, which suppresses cyclin-dependent kinase 4, and you need CDK4 to complex with cyclin D in order to activate E2F, and the interaction of CDK and cyclin D with E2F is what throws cells into the S phase. So P16 is a tumor suppressor gene. Again, this is not something you have to be an expert on. It helps, but like, when is it going to be of much use to you? Clinical presentation, painless neck mass. So the neck mass can be a primary lymphadenopathy, right? Could just be a local infection. So when you see a patient present with a cervical lymph node, first thing you want to do is touch it and see if it's painful to the touch, because if it is, probably an infection. But if they've got this big rock of a lymph node and you're pushing on it and they're like, yeah, that's fine, keep pushing on it. You push on all day, that's bad. Because big swollen lymphadenopathy, big swollen lymph nodes that don't have any pain associated with them are very often metastatic or primary lymphomas. So that's on your differential. So if the patient's got pain in the lymph nodes and a cough, right, and maybe they're running a fever, and they're in that late teens, early 20s demographic, you're thinking mono. And if they've got a positive history of mono and then the lymph node comes back, well, then you might be thinking some sort of EBV-related secondary cancer. And the neck mass is going to be a metastasis in nasopharyngeal carcinoma. But where I'm going with all this is that in a lymphoma, a B cell or a T cell cancer, a swollen lymph node may be the primary cancer. Patients can present with ear pain, remember, due to that characteristic anatomic location of these nasopharyngeal carcinomas at the fossa of Rosenmuller, right next to the eustachian tube. So you block the eustachian tube, you can't equalize pressures in your ear. And you can get nasal blockage and maybe even nosebleeds, and then compression of other intracranial structures due to the growth of this nasopharyngeal carcinoma. Last things last, talking about clinical presentation, is that if you suspect mono, you're going to get a monospot test, and that's what it's called, but it's also technically called a heterophile antibody test. And so those two things are synonyms. Almost all patients with nasopharyngeal carcinomas demonstrate positive EBV serology. IgA is a good diagnostic tool, and that's because IgA is the immunoglobulin specifically expressed in the respiratory mucosa. And remember that a lot of bugs that cause upper respiratory infections and sinusitis and the like have an IgA protease, specifically strep and Haemophilus and Neisseria, right? They can inactivate IgA, and that's what makes them efficient colonizers of the respiratory mucosa. So the best possible test is going to be EBV DNA, I believe. Because again, IgA might go up or down depending on other factors, but EBV DNA, once you get EBV DNA, once you're infected with EBV DNA, then it's going to be there in the blood. And then especially if the virus is in the lytic phase, popping open cells, you're going to see a huge amount of it in the blood. And then you're not going to see the cancer unless it's in the lytic phase. So that's how I'm connecting the dots. Nasopharyngeal carcinoma, high rate of local recurrence and metastasis. The jugulo-digastric lymph node is involved, and the posterior cervical chain is involved, so the back of the neck. That's important to know. And then the most common sites of metastases are bone, then liver, then lung. So I could see one question coming from there. Again, it doesn't strike me as remarkable knowledge, but that's the sort of nitpicky little detail that examiners like to throw in to differentiate the 80% from the 90%. We diagnose it with MRI, and we treat it with radiation. So that's tumors of the upper respiratory tract. I think you're going to see a question on just a benign vocal polyp or node, right? I think we're probably going to see a RRP question. Remember that HPV is the big exposure factor for that, and that juveniles, kids can get HPV transplacenally. Laryngeal carcinoma, that is for sure going to be one question, if not two. Big risk factor is smoking and alcohol. And then just pay attention to the keratinization of the outside and then the gross anatomical location of all of these different tumors. And then nasopharyngeal carcinoma, one question, maybe two on that as well. Remember, it's got a huge association with Asian descent. It's endemic to certain parts of the world. It's the Hpv virus, which gets into B cells and laryngeal epithelium through attaching to CD21. That's its surface receptor. And EBV is also associated with episodes of mononucleosis. Posterior cervical lymphadenopathy. That's another thing for the carcinoma. All right. Thank you very much. See you next time.